Okay, so we are starting our second segment of the expert series, and we will be talking today about examining the facts of disparities in healthcare among underrepresented populations. Your speakers for today are myself, Dr. Keisa Boykin, Alicia Day, and Marlena Jackson. Just a brief bio about each of us. I am a faculty member here at the University of St. Augustine campus. I'm an assistant professor in the OT, the MOT, and the OTD program, and I've been here 3 years. Alicia Day works within our admissions department here in St. Augustine. She is actually a mission specialist. Don't let me take that away. She earned her Master's of Public Health degree from George Washington University and her bachelor's degree in music and history from Florida State University. And Marlena Jackson works within the enrollment department. So we are your presenters today for this topic. Again, the topic is examining the facts, disparities in healthcare among underrepresented populations. Before we get started, just want to remind everybody to mute yourself in order to minimize distractions, but also this segment is being recorded, so to avoid the recording having background noise. Okay. All righty. So I'm going to pass the baton to Alicia. Oh, actually, no, I'm not. I'm going to tell you what our objectives are for today. How about that? So our objectives are to define health equity, identify social determinants of health, identify the underrepresented populations in healthcare, superficially explore the root cause of health inequalities, to discuss the impact of disparities, and to present the tools to promote health equity. Alicia?
So one of my favorite things to do is to start with quotes from some of the leaders that have inspired me through my public health journey. And one of those is from former President Barack Obama. And during his tenure, he actually was able to get the Affordable Care Act, as we know, the ACA passed, which was one of the largest landmark healthcare acts in the history of the United States, passed through. And during this time period, he was quoted as saying, "Ensuring access to quality, affordable healthcare helps create the opportunity for all citizens to achieve the American dream. Despite advances in medicine and technology, disparities remain in our healthcare system for too many Americans, including racial and ethnic minorities." And this disparity is not something new. Dr. Martin Luther King Jr. was quoted as saying, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." This leads to the need to promote health equity. What is health equity, actually? And what it is defined by the World Health Organization as the absence of avoidable, unfair, or immutable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other means of stratification. Health equity, or equity in health, implies that ideally everyone should have a fair opportunity to attain their full health potential, and that no one should be disadvantaged from achieving this potential. When equity isn't achieved, the outcomes of populations regarding health conditions suffers. Therefore, all public health programs, as well as clinical interventions down to one-on-one treatment from caregivers, should take the social determinants of health into consideration. The social determinants of health are basically the pillar that public health programs and interventions stand on. They're everything other than the health condition that your patient has. Everything that can impact their health that isn't an actual health condition. Things like their economic stability, their education, their availability to health and healthcare, the neighborhood where they live, the built environment that they live in. Do they live in a house, an apartment, a shack on the street, someplace like that? Or the social and community context, which can even be broken down into racial, social, sexual identity. If you look up social determinants of health, depending on the article or the research you're looking at, these can change and vary, and you can find up to like 20 of them at any given point because they can be broken down into such a microcosm and variation. But all of these things are basically everything that can impact the health outcome or their treatment or their availability of treatment or anything that has to do with the health care reason that this patient is sitting in front of you that day. Or if you're looking at a community-wide organization or impact, the thing that will actually create the issue, or something like you can treat a patient for their heart condition, but if they can't afford their medication, then that impacts how you treat them and how they're able to adhere to that care. Their education, if you're speaking to them and they don't understand what they're saying, but you're a doctor and they're just nodding along and they just understand, being able to explain things in a way that they can understand, have those plain terms, that plain language, common terms that I know that all of the professors at USA love to talk about, are important pieces of that so that they are able to take that into consideration of the patients who you're working with. And when there is no health equity or there is a lack of that, you get into the area where there is healthcare disparities. And those disparities are the differences between where that patient is or where the group of people is and equity itself. So if we want to move to the next slide. Since Marlena has not been able to join us, I will pop in with that. Healthcare disparities refer to the differences in health and healthcare between groups that are closely linked with social, economic, and or environmental disadvantage. Underrepresented populations in healthcare can be those who are underrepresented due to their race or ethnicity, their socioeconomic status, age, location, sexual orientation. If you recognize that this is actually very similar to those social determinants of health. They are commonly viewed through especially the lens of race and ethnicity, but they occur across a broad range of dimensions. For example, disparities occur across socioeconomic status, age, geography, language, gender, disability status, citizenship status, and sexual identity and orientation. Federal efforts to reduce disparity focus on designated priority populations who are vulnerable to health and healthcare disparities, including people of color, low-income groups, women, children, older adults, individuals with special healthcare needs, and individuals living in rural and inner city areas. These groups are not mutually exclusive and often interact in important ways. These disparities also occur within subgroups of populations. For example, differences among Hispanics in healthcare based on length of time in the country, primary language, immigration status. You can say that they're all of the same race group, but those different factors can impact their healthcare as well and create different disparities. This also means that these disparities can also occur across the life course, from birth to midlife to older adults to children, and the access that they have across those different ways. When you're looking at disparities, the outcomes can vary for different groups, different ages, all of those different variations. And right now we're trying to give kind of an overview so that we're not overwhelming you, because it's very easy to get lost in the weeds when you start breaking things down into the different groups and the different races and the different sexual orientations and all kinds of things. So we're just kind of giving over those, but as an example of different disparities that come out of these, the mortality rate for African American infants is 2.5 times greater than those of Caucasians. There's also related to that, African American women have higher rates of maternal issues during pregnancy and childbirth. Hispanic and African American youth are substantially more likely to die from diabetes, both type 1, which is the juvenile onset, and type 2, than those of Caucasian race and ethnicity. The LGBTQ population experience worse health outcomes than their heterosexual counterparts. And people who are both LGBTQ and members of a racial or ethnic minority will often face the highest level of disparities because they're getting hit on both two of those points, not only their sexual orientation, but their race and ethnicity. One of my favorite quotes from this year's Pride Month was that if you aren't taking into account the people experiencing pride who are racial minorities, then your pride isn't really fully encompassing the community. They were speaking in particular about African-American trans women and things like that, because they face an entirely different set of circumstances that lead to health outcomes and racial profiling and all kinds of things that that those who are white or Caucasian or Hispanic don't in their experience of life and health outcomes. So moving on with the health disparities in the United States, when you're looking at when health equity isn't achieved, these things mean you have to address those differences as best as you can. You're looking at the differences between those who are adolescents and those who are elderly. You have to look at where your patients or the groups of people you're intervening with live, work, play, travel. All of these things affect the cost of services, the availability of services, where they live, how they live, what those buildings are made out of, how they have to understand. Food deserts is a huge issue where if you can tout better nutrition for groups of people, but they don't have access to it, then you're basically talking to a wall. So everybody knows that good nutrition is something that really has an impact on every aspect of your health, because everything from obesity prevention, type 2 diabetes, to your ability to recover from illness and injury, all of those things, you have the problems that you actually cannot address that, because if you don't ask how these people eat and how they have access to that care, that's a question that's going unanswered, and making assumptions that they have the same access that you do is a dangerous way of doing it, and that's actually creating a health disparity in its own way. Another major issue is that there are huge evidence gaps in research. You have so many trials and studies that are done on white people. Just the easiest way to put it is white people, and medications that are tested only on men but not tested on women. Medications that are tested without any thought as to race or ethnicity or heritage or genetic background. Ashkenazi Jews, for example, all of these things, you can test it in a city population, but you don't test it in people who live in a rural area. You can test a public health intervention that's great for reducing childhood obesity in suburban areas, but does that work in rural areas? Does that work in inner city areas? All of this means that there is never going to be a one-size-fits-all solution. And with that, I'm going to step off of my public health soapbox and hand it over to Keisa, to Dr. Boykin, because if I keep going, we'll be here all day. Because one of my biggest things is that the American mindset is that those who have overcome adversity, either because of whatever reasoning, where it's racial, it's sexual orientation, it's gender-based, those who have pulled themselves up by their bootstraps are just they're the ideal of the American idea. But what that completely ignores is the entire sets of populations of people who were born without boots. Those who with circumstance and with other ways who have absolutely no say as to where they were born, how they were born, what they were born, all of these things, they have been given a hand of cards that they were not dealt. And if you do not address those populations, you're only addressing the population who can handle things in a completely different way. So I'm going to hand it over after that really impassioned speech to Dr. Boykin, just to remember, when you're looking at people, don't assume they wear the same shoes you do.
Fair enough and well said. I mean, it's hard to argue. There's moral arguments to promote health equity and how it's advancing and progressing towards health equity. And that argument in and of itself produces economic, national security, and other benefits for our nation. The premise that social mobility, opportunity to succeed with hard work, and opportunity to achieve prosperity exists in is fundamental to the American dream. Everybody wants to be successful. People migrate to the country because they want to live that American dream of success. Literature demonstrates that worsening social, economic, and environmental factors are affecting health in serious ways that compromise opportunity for all. Health is more than life expectancy, infant health, and fitness and nutrition. It's the ability to lead a full and productive life. Additionally, an opportunity to achieve good health is crucial to the U.S. democracy, national security, and economic vitality. The burden of disparities lowers the nation's overall health status and its ranking relative to other nations. So these are facts that many of us already know. We know that health disparity exists. We understand that health disparity looks at infant mortality, it looks at nutrition, food deserts, those type of things. But to give us a few statistics, and not to bombard anyone with statistics, but just to give a general idea, in 2018, if we look at this national snapshot, the percentage of people living in poverty, ages 25 and older, and this is not including children, was 11.8%. A high number when you consider how many people are in the United States. But if we break that number down by race and ethnicity, those that were Black or African American were 21.1% more likely to live in poverty. Mexican Americans were 18.1% more likely to live in poverty. Whites or Caucasians were 8.1% likely to live in poverty. If we were to look at this line of poverty, households that spend more than 50% of their income on housing is 16.2%. So we already said 11.8% of individuals over 25 are living in poverty, 11.8%. But of that 11.8, 16.2% of those individuals are spending more than 50% of their income on housing. That's a large amount of their monthly budget. Of that 50%, of those individuals, if we look at it by race, 23.9% of African American are spending more than 50% of their income on housing. 22.3% of Hispanic and Latinos are spending more than 50% of their income on housing. Caucasians are spending 13.5% of their income on housing. Two or more races, 18.4% of their income on housing. Asians, 18.1%. Again, you see that this is above the national average in 2018. When you look at why we have infant mortality, if you're looking at life expectancy, if you're looking at fitness and nutrition, if you're looking at chronic diseases, just taking this one snapshot of this particular area, how much money are they spending on shelter, a basic necessity, on that lower ranking of Maslow's hierarchy of needs? You get a general idea of how much money they have left to pay for medication, food, the things we just talked about, healthcare, all of that. They don't have a lot left. If we look at households that spend more than 50% of income on housing by educational attainment, if they had less than a high school diploma, they spent 26.2% of those individuals spent more than 50% of their income on housing. So if they had a high school diploma, it was 18.1% of those individuals spent 50% or more on housing. Some college, 17.1, an associate's degree, 13.8. So you see, as individuals become more educated, they're spending less of their income on housing. Is that because they're more educated and they know better? Or is it because they're making more money and they move further away from the poverty line? Either way, either no matter the side of the argument that you're on when it comes to this, there's an issue. You see the disparity. You see the trickle effect of how it affects other areas of these individuals' lives. So let's talk about tools to promote equity. So there's a clear urgency for the nation to fully address health equity, or more so, health inequity. Analysis of current trends provides evidence of persistent health inequity. We've talked about it, but there is reason for optimism. Many organizations in public and private sectors have recognized this, making health equity an explicit or implicit priority. These organizations span the sectors of finance, public health, community development, academia, here we are, USA, and beyond. Local, regional, and state governments have also taken on issues essential to achieving health equity. So tools to promote healthy and affordable foods, neighborhoods that with open space for physical activity, and community safety. So we've seen where there have been food deserts. Alicia talked about food deserts briefly. So you see where there are grant opportunities to provide foods in those areas where there isn't food or isn't stores within walking distance or within public transportation distance. And then neighborhoods with open space, you see more urban development and rural development where they're trying to encourage physical activity in a safe environment. And then community safety, whether it be neighborhood watches or educational type programs to promote safety within the neighborhood, not necessarily where individuals are coming in to run the neighborhoods for the individuals, but teaching the individuals how to manage their own environments.
I wanted to pop in real quick with something. I apologize for interrupting, Keisa, but
No.
with also cultural sensitivity studies, where when you're looking at the community that you are practicing in, making sure that you are aware of who lives there and where they come from, how to communicate with them properly, how to be sensitive to them. One organization that comes to mind is from Detroit. It's Access Healthcare. They focus on the Arab American population in the Detroit area, which is actually I think it's the largest Arab diaspora outside of the Middle East. And they focus specifically on culturally sensitive cultural competency, but also cultural humility in those areas, to say there's a different standard for an Orthodox Muslim woman coming into a doctor's office for treatment than a white woman or Hispanic woman. So they create places where it's safe for that woman to seek treatment, or to, I know they were working on an obesity prevention program, or and healthy eating organization. They were looking at doing women only exercise classes where they hung sheets over the windows, and these women could come in a safe, culturally aware area with no men around, practice and socialize, but also do healthy activities, because this is Detroit's way different than the Middle East, if you didn't know. And so with that, you have first generation and second generation women who are able to work together to find a place that is culturally sensitive. And a lot of the people who work there are also aware that they don't know everything. And so taking themselves out of it and listening to the community around them of what they want and what they need and what works best for them is not just cultural competency, but cultural humility, and understanding that you don't always have to relate your experience to theirs. You just need to listen to theirs honestly and to take it under consideration. And that in itself promotes equity, because you're not trying to reach them, you're meeting them. Does that make, there's a difference in that verb for a reason. As a cisgender white female, I put myself out of as many situations as I can in a healthcare situation, because my experience is not something that many people in any other way can experience. And I'm fortunate in that, but I want to listen to those to help others have as close to a situation as I can, and that way. So with health equity, listening and understanding and being willing to act on those things, and not put yourself in their shoes so much as let them tell you what their shoes feel like. I'm back on the shoe thing again, Keisa.
You like those boots.
I like my metaphors. That's how it is. But I just wanted to make sure that we brought in that cultural competency and humility is a best way for promoting health equity as well.
Absolutely. Very important. So let's talk action steps before we get to our conclusion. As future healthcare providers, as current healthcare providers, as those who teach healthcare, future healthcare providers, it's important to understand the history of the community before developing engagement. What does that mean? You gotta know who you're working with. Simple terms, simple words. Know the community, get to know the community. Educate yourself first before going in to make change, before going in to impart your knowledge, because You may have learned a new skill. You may have learned a new tool, have a new way of doing things, and you want to share it with the world. However, when going into communities, you should understand the community first. Know the history. A lot of times, communities have seen programs come and go. They've come with their new shiny tools, but they leave. And the community may not have been properly educated. They may not have been left with the tools. And so you want to know that history. You want to know that. You want to understand that first before you develop engagement. Build community relationships early. You're there for a reason. You're not there for an agenda. Get to know the people. Build a relationship. Let them get to know you. Shouldn't just be one-sided. So building that relationship, never never underestimate the power of building relationships. Assess and address. Assess and address the organizational barriers to community engagement. You may come from an institution, if we're using University of St. Augustine, where there may be some issues with engaging with the community. Now, that would not be the case here at USA, but you never know. Depending on where you work as healthcare providers, future healthcare providers, there may be barriers, and you need to know that before you go in making promises. You want to know what you're able to do, what's feasible, what's your length of time in this engagement. Understand all of this before you go in. So you want to assess what the community's needs are, address them, but you also want to know what's your organization's ability to meet those needs. And then select the engagement that's appropriate based on the context. Know what's within your scope of practice. Know what's within your ability to provide. And based on that, determine how you're going to engage. What's going to be most feasible based on your time frame, based on your budget, based on your bandwidth. And understand and address the barriers that may prevent community participation. Again, it's not one-sided. This is a two-sided relationship. So there may be things in place that will prevent the community from engaging in the activity you have planned or the service that you want to provide. You need to understand that and address whatever barriers that may prevent their participation. Now, there are systematic root causes of health inequities in this country that can be overwhelming and that will take considerable time to address. We realize this isn't an overnight solution. This is beyond four series. It's a big undertaking. It'll require system level changes to eliminate structural racism, reduce poverty, improve income inequality, increase educational opportunity, and fix laws and policies that perpetuate structural inequities. Until these root causes are addressed nationally, health equity will not be fully realized. However, actors at the community level, policymakers, business, state and local governments, anchor institutions, hello, University of St. Augustine, and community residents and community helpers, hello, my physical therapists, occupational therapists, speech therapists, nurses, and those who volunteer are agents of local change who can have the power to change the narrative and take action that will promote health equity. This is doable. We just have to start from the grassroots until those up in higher powers make their changes. What questions do you all have?
I have a question. What, like with that, like I obviously understand that it is something that's just not going to be overnight and like we have to take a lot of time to completely understand what's going on, but like what can we do while we're in school before we go out into the field to try and I don't want to say I don't want to say like eliminate this because it's going to be present for a while, but like what can we do at this point in time, like in the here and now?
Educate yourself. So attending these type of series cultural competency courses. Um, what else would you say, Alicia?
I think the first and most important thing is being open to any and all experiences that may be
Mhm.
coming from some place that makes you feel uncomfortable, because um, I have had many PTs tell me that if it's uncomfortable but it doesn't hurt, then it means you're working hard at it, and it means that's where the change happens. So if you're uncomfortable but it doesn't hurt, then lean into that discomfort, lean into the change, and put yourself in a situation that's not dangerous. We're not going for danger or anything like that, but maybe a clinical that isn't somewhere you thought you wanted to go. Lean into a situation where it's something that you want to learn more about rather than a place that's convenient, if that makes sense. There's a lot of resources if you're looking for things to learn about. I know that you have so many lectures and so many things to do as well, but the Harvard Public Health School, Yale, all have great online lecture series as well, which make great driving because they're often not very monotone. Because if you haven't noticed, public health people get really excited. But they do great panels and things about different pieces of cultural competency. There's all kinds of things from experts where they bring people in and talk about very specific health issues, but also ways you apply programs and how those programs can be brought into clinical settings and how those clinical interventions take shape, and just be open to it and check yourself in the way that you think, if that makes sense. When you find yourself thinking something that sounds stereotypical or sounds in a way that it's kind of like a knee-jerk way, and wonder if that's your conditioning from the way that you've grown up or where you've grown up or everything. I mean, we're all here at a university, a private university, for a graduate experience. We're all within a subset of people who are already in a place of some sort of privilege because of where we are. So understanding that and being open to listening to it and being willing to find ways to put that aside and practice putting it aside. Pro bono clinic's a great way.
I would add to that, Miley, Jennifer's going to be, or Dr. Summers will be talking about action steps when she talks about advocacy in a couple of weeks. So like I said, keep coming to these sessions. There are two more, so the fourth one, she'll be covering that. But this is also a great area where you can bring these topics up in class. And we do case studies all the time. And in those case studies, we can add what if this individual was a person and suffering, I'll say suffering, but a person of color, a person from the I always get this wrong,
It's
LGBTQ population. If this was a person living in poverty, we can always add those twists to those case studies. Were you going to say something, Michelle?
Yeah, this is actually, you guys have my wheels turning because I'm hearing and I've been thinking about this for a long time. There's so many opportunities. I think we can be all more cognizant of embedding some of these cultural biases and in situations right into our simulations. So I'd love to work with you and talk to you more about that at a later time, Keisa, about maybe
Absolutely.
doing some simulations directly that are directly addressing cultural bias and things like that.
mm-hmm.
And and to speak to Alicia's point again, that uncomfortableness, feeling that uncomfortableness in a safe environment is awesome to have that opportunity, because as healthcare providers, when you're in it, when you're treating that individual, you have got to roll with it the best way you know how. And that may be good, that may be bad. But the beauty of the University of St. Augustine is we do have that CICP opportunity to simulate with different clients and different cases and add twists to those cases, to try adding in those social determinants. I have a comment in the chat box from Dr. Shotwell. Molly, maybe asking questions about people. Oh, went by so fast.
With genuine humility about lived experience, being open to listening to them. Dr. Petrotelli also said, doing like an occupational profile and asking things rather than assuming anything. Never assume in any way that you have any idea about anything. Go in as a blank slate. We would do in my master's program for public health, one of the first things you learn to do is like a situational or a community profile, and you go in and you're like, oh, it's a suburb outside of Cincinnati, X, Y, and Z. It's totally this. This is what a standard suburb looks like. It's like, no, not necessarily. You know nothing about suburbs. Go in like you know nothing, and ask about the population, ask about the standard education, ask about the median income, ask about the lowest income, ask if there's public housing, ask if there's other things, ask which subset you would be aiming towards, what age groups, the race, ethnicity makeup, all kinds of things. Just ask all of the questions you can and be honest and open to listening to the answers.
Any other questions? Eric?
Yeah, I don't know, this is a larger conceptual question, but since we have some people administrative on this call, because the things that you show, I think probably aren't, the thing that we went over probably aren't surprising a lot of people on this call. I mean, hopefully some of us are learning something, but it's a little bit of preaching to the choir. This is the people who are interested in making change at the university. And I know at the beginning of this, the university did make some statements and we have this committee. I guess my question is, because this education is important, and I've heard you hear that language of denial and dismissiveness even throughout our university, and I've heard it on some of these calls and within students and faculties. And my question is there a way as a university, maybe, like, all these ideas are great on the micro level, but and I know that we have our mission statement and our vision, they kind of tangentially get to this some stuff, but I guess my question is, could we think, especially since we're a B Corp university, if maybe we could be more explicit in codifying these in our language and our values and our programs? Like, I know in our BEADS course, we talk about cultural sensitivity and, being family centered and all these things, but I don't know. I feel like maybe there's a way that we could better really just put it out there from the start of the university and say, this is one of our values, and actually maybe even have in our mission and vision to kind of create a more, equitable profession and more equitable, student environment, not only student, but healthcare environment, that we're not just trying to create good healthcare practitioners, but we're trying to create, and I know that ethics are in there, but a lot of people who see themselves as very ethical also don't see this as a problem. So I think it would, I don't know, I'm rambling a little bit, but I feel like that maybe as a university, like, this could be a moment where we could embrace this more implicitly and make it part of who, and we keep talking about distinguishing ourselves and being a leader, and it seems like this could be a great opportunity to really demonstrate that and show that and kind of get beyond just talk.
I agree. Great question. Great comment. Question. I think it's perfect for Dr. Goldstein. I hope you were catching all of that. So on a macro level, Dr. Goldstein, what differences can we make?
Sure, I was catching all of that and really enjoyed both of you. Thank you, Keisa. Thank you, Alicia, for your amazing talk and I think thought-provoking content that we do need to think about. So, I think we want to approach this in many ways, right? I don't think there's a single layer here, and I think that was sort of part of the theme of your talk, right? Was that this is multifactorial, this is layered, this has to be nuanced, and so I think we're doing this in a variety of forums, right? We're engaged in town halls, we're engaged in conversations with our students. The IDEA committee under Keisa and Ryan Davis are hard at work, I think, trying to gather information from a variety of sources and to help the university decide how to go forward. And I think, Eric, that is the driver of this process, right? What we've said is we have a group of dedicated faculty and staff that are going to really help us drive how we need to respond as a university to be inclusive in all of its forms. And if that drives changes to our vision statement, our mission statement, or our core values or our ILOs, I think those all would be under consideration. I think this also works from, if you will, I think your question or your comment was sort of a, if you will, top down, if you don't mind that visual. but I also see it as bottom up at the same time. Conversations I'm having with what is each program in each campus, in each cohort doing relative to diversity, equity, inclusion, in the curriculum, because the students have asked for that, right? The students have said, I want that more front and centered and in the foreground of the curriculum. So, I saw in the chat, for example, and there's been emails to, actually literally today, right before this meeting, between Maria, Vivian, and I, talking about the simulations that are being planned that are going to have, again, if you don't mind the term writ large, a diversity focus toward them. So again, I think we're coming at this from all different levels. And I think what's positive about our approach is that it's not the, okay, we did this, we've checked off the box, we have a committee now, that's it. Again, I think we're attempting to come at this from various levels. So again, I don't know if that quite answers the comment or questions, but open for the discussion.
Yeah, yes. and I just put a comment in the chat, Dr. Boykin. I know in our last session you talked a little bit about the IDEA committee, and I know we didn't get a chance to do it in this one, but this might be a good time to kind of talk about what you guys are doing. And as Dr. Goldstein alluded to, I think this fall we're all about the action, the projects, the things that we can do to move these initiatives forward. And certainly step one is educating ourselves, right? And becoming aware and having the dialogue. But the IDEA committee is really leading the charge in helping us channel what we've learned and what we're observing in the world and what we're learning into actionable items that can really produce change at various levels.
Yes, the IDEA committee has been very busy. I see several of the committee members on here today, Na and Connie. It's awesome to have the support. We've been busy in terms of what to do with the information that we've gathered already. So we've had the town hall meetings, and we have been charged with what are the action steps? Where do we go from here? And so we've been working with the consultant to determine what's feasible. And we are working, just as Eric mentioned, how do we get to this macro level? How do we get to those individuals who aren't on these, who don't attend the town hall meetings and who aren't attending the series? And we are considering that. We are thinking of, how do we reach everyone? Because the message is important and applies to everyone. As I said, we're educating future healthcare providers, and we want the message not necessarily to be the same, but we want the sensitivity, the competence, the humility to be the same. Does that make sense? And as the IDEA committee, we are presenting to the executive board, we are presenting to the leaders, and we are also, wanting to let you all know, as the faculty, as the staff, as the students, what we are doing. So we're also working on newsletters to let you all know what is going on. So the IDEA committee is very busy. We have a lot of different plans in play and a lot of different movements and motions in play. So we are trying to do our part to make sure that what was said in the town hall is not only heard by the IDEA committee, but heard by our leaders, and that action is being taken so that individuals can feel more included in our university. Reading this message from Dr. Shotwell.
I guess, Keisa, it's kind of like, like if you and I are working side by side and I recognize discrimination in a clinical environment, either from my colleague or of a patient or client, what kinds of things in your experience, me being a white person, have you seen that have been helpful things to say or unhelpful things to say? I think students might appreciate if you have any wisdom there.
That's a tough question, because now I have to think of a particular scenario to answer that question, right? But I think acknowledging the fact that something was said is first, right? Something that was said that was inappropriate. And if you are there with me, your agreement with me in terms of something was said that was inappropriate is extremely helpful. Not pretending you didn't hear it, not pretending that it was funny. That's helpful all by itself.
Yeah, silence is being complicit in a lot of things.
And sometimes I even as a Black woman, you are still shocked by some of the things that people say. You don't always have the perfect retort. And as a healthcare provider, you have to maintain a certain level of decorum, right? You can't automatically jump off the handle because someone has said something inappropriate to you. Jennifer, you use ouch and oops policy with clients and with students. What does that mean? You're muted.
I do that, and then I can't find the unmute button as if it's my first time. So I bring this up in the classroom. I don't know if any of my students are on the call. I don't necessarily recognize all the names, but we use an ouch oops policy, and I used to do this in practice too, where because I worked in the inner city of Chicago doing home care, and I recognized that there were definitely some cultural differences, and so I brought this into clinical practice and I bring it into the classroom now. So ouch oops is basically saying, I'm your therapist, I'm going to be here for 5 weeks or whatever. I want to make sure that I'm always open and honest with you and you're always open and honest with me. So I want to start this ouch oops policy. And then I explain it. So ouch is if I do or say anything where I cause an ouch, please point it out so I can find the words to better myself with the oops, and I can explain maybe an oops, or maybe I came across explaining something in an insensitive way, and then I'm going to say the same thing for you. I might do ouch oops to you, right? And I do this with a classroom, and they do like it. We do it in the psychosocial OT class when we're talking about cultural humility, because it's a very heavy day. We talk about microaggressions and what that means and things like that. And so sometimes I have them write down their ouch, and all of us have experienced that. And then a time where they wish they'd have the opportunity to oops and say, okay, I might have said something to Dr. Boykin one time. I wish I would have had the chance to hear her point of view, and I never allowed that space. So that's my little ouch oops policy that just kind of opens the door for conversation, recognizing we all are human and we all say things that aren't necessarily supportive or indicative, or it's a lack of culture. When I worked in the inner city, I remember I asked a client one time, what's that smell? And I go, so there was a strange smell. And she goes, honey, that's crack. And I'm like, and she just started laughing at me. And this was the time, like, I had to apologize, or, and we made it into an opportunity for teaching me, because I just, was not really aware of what was happening in her home. And then I turned it to an occupational therapy moment. Like, how is this impacting you? Because she was this woman who had an orthopedic issue. So it was.
But wait a minute,
Yeah.
Dr. Summers. You said crack cocaine?
Yeah.
That's a whole nother issue. That's illegal. That's beyond cultural competence.
And it wasn't her. It was in the apartment complex. And I thought something was like burning. I didn't know what it was. I never smelled anything like that before. And I just wanted to make sure she was safe, because I thought there was like gas leaking or something. And she's like,
I thought it was in her apartment.
No, but she had to go down the stairwell, which is what the physical therapist was working on with her. And I was trying to get her to get back on the, the L system that she uses to get to her doctor's appointments, the subway type system there. And so it impacted our treatment, because she had to know when she could leave safely to leave her house. This is a social determinants. She can't just go willy-nilly leaving the house. She had to know when it was safe for her, right?
Certainly.
That's just an example, but this ouch oops policy allows me to make mistakes, and it allows me to learn, and it allows the students to make mistakes and learn too, and have that that transparency and that safe position, as we are their models in that way.
And so, Dr. thank you for sharing that, because I think that's helpful. Dr. Pissifero wanted to have us talk about
interpreting data.
Yeah.
So let me put up our reference slide, but also Healthy People 2020 is a great place to find references. The World Health Organization is a great resource, as well as, I'm forgetting one.
The CDC was another one that was huge.
Is great as a reference area for social determinants. I do thank everybody for being here. I think we had great dialogue during this session. It was enjoyable. It sounds like we're all very passionate about this area. We've got some ideas of what we can do next. In terms of simulations, and Dr. Goldstein has given us some hope in terms of what's going on a macro level. I hear passion and voices in Dr. Summers and Mr. Surratt. So thank you. Thank you for being here. Thank you for being engaged. Are you on the bestseller list, Dr. Surratt or Mr. Surratt? He's on. I'm like, wait a minute, is that a reference or?
I just feed it with my paycheck. It doesn't feed me, I feed it.
So
I didn't want to overlook a resource.
One of my favorite references is that when you're looking at things that reference data, anywhere you see percentages of populations or anything like that, treat it like a Wikipedia page, where yes, the Wikipedia page and the article has a lot of great synthesization, but it could be completely skewed by they want to prove a point, they want to prove a hypothesis, they want to make their data look good. But if you go all the way down to that reference section that looks like hieroglyphics, if you're not used to reading the data, go into those things, and if they do a study, make sure you look at the composition of the study. Look at where they found their volunteers. Was it blind? Was it double blind? Was it completely volunteer based? Who volunteered? All of those things. Look at that and say, okay, this is great that this group had a great outcome for orthopedic rehab on broken wrists or whatever, or all of these things. But if you make sure that you look at it and say, oh, but it was all from Portland, Oregon in a higher income neighborhood, and they just happened to look at a bunch of fourth graders who broke their wrists rollerblading or something, all those things, instead of, it's a skewed data. But if you look at, say, a really high participation rate for a national level survey and see that it comes from all strata, that they even go down and break it in by the demographic data of income and race and sexual orientation, the more ways that they're able to break down their data means that they have looked at it from different ways. They have looked at the data management, they have run it through SAS or some other program that was the bane of my existence in data management in grad school, and all of these things, and they've broken it down because they looked at their data to do different ways of understanding that. And the more ways they've broken it down mean there's more variations in that subset, in that group. So if you're interpreting data and they just give you this great, really complimentary percentage, understand that it's probably not what you think it is. Or that it's probably that they've skewed it. If they don't reference something specifically, then that's a problem. Make sure that any article, any study, anything like that has the references to back up their data claims.
Absolutely. And Dr. Goldstein has placed some great references in the chat box: the National Institute on Minority Health and Health Disparities, and then the CDC Strategies for Reducing Health Disparities. So make sure you copy those before you leave. We do thank everybody for attending. Thank you, students, for being interested in this topic. It's important. It'll help shape your future practice. Thank you, everybody, for being here tonight. Have a good one.
Thank you. Ask good questions.
Thank you, Keisa. Thank you, Alicia. It was wonderful.
Thank you.
Thank you.